This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Happy holidays. We have a journal club. This morning is our last Friday Fellows Conference of the calendar year. So quick programming reminder is you might not be surprised to hear we are off the next 2 Fridays and we'll reconvene on January 5th. But today we have a journal club and our first presenter is Dr. Andrew Murphy. Dr. Murphy is a second-year fellow in the clinical track, did his residency at the University of Pittsburgh. And as you can see today, he's going to talk about the Orbita 2 trial. Dr. Murphy, take it away.
Thanks, Dr. Williams. So yeah, talking about Orbita 2 today, or a placebo-controlled trial of percutaneous coronary intervention for stable angina. I have no disclosures, just jumping straight into it because there's quite a bit of background. So far, that have shown that there's no difference in MI or death rates with PCI compared to medical therapy. And this is in a number of trials dating back decades, but some of the more notable ones, Courage, Berry 2D, and the ischemia trials more recently. So that leaves angina relief as the main reason for PCI and stable coronary disease. Currently, guidelines, including the recent ones released this year for chronic coronary disease, recommend anti-anginal meds as the first line therapy with PCI reserved for people who remain symptomatic despite medical therapy. And then historically, data from unblinded randomized trials have shown improvement in a few different metrics, notably exercise time, angina scores, quality of life. And there is evidence, however, that the placebo effect is actually even more pronounced for invasive procedures compared to medical therapy alone, which leaves the true efficacy of PCI for stable angina unknown. And this is just showing that in the recent chronic coronary disease guidelines 2023, that this remains the recommendation that invasive coronary angiography is recommended for making therapeutic decisions with the goal of improving anginal symptoms after GDMT has been trialed and maximized. So one of the earlier papers that was really foundational in terms of our current paradigm was the ACME trial back from 1992 that took patients with positive stress tests via thallium, MPIs, or treadmills that had stable angina who were found to have severe disease on invasive coronary angiography that were randomized to either POBA, to PTCA, or to medical therapy. I do list here, there were a couple of notable exclusions, most notably female sex was excluded entirely. Some of the other exclusions were similar to modern trials, multivessel coronary disease, CTOs, LV dysfunction. So essentially, patients were randomized to either medical therapy or POBA. Patients were actually encouraged to get repeat POBA if they continued to have symptoms. And what they saw at 6 months was that 64% of the intervention arm was free from angina compared to only 46% for the medical therapy arm. And then the PTCA group was able to exercise a little bit longer, 2.1 minutes longer on the treadmill compared to 0.5 minutes longer for the medical therapy group. And so this isn't the only trial that is similar in its design, but I think this is representative of a lot of foundational work that led to this clinical interpretation that, in this instance, POBA, but PTCA in general, offered earlier and more complete relief of angina compared to medical therapy, and that people had better performance on exercise tests. So then questions arose in terms of how do we really validate this and get rid of some of the placebo effect, because all of the prior data before Orbita 1 was unblinded. So this brings up this kind of idea that the overall effect of an intervention on symptoms equals both the physical component and the placebo component. So then that raises the desire to subtract the placebo effect to just understand the isolated physical component. And then it's appealing and it's tempting from both the patient's perspective and from our perspective to imagine this very linear relationship. This is kind of a key concept between anatomy, so severe stenosis or severe stenotic lesions, resulting in changes in the physiology, so decreased oxygen supply despite an increase in demand, that then leads to ischemia, that then leads to symptoms. So Orbita 1 came out in 2017, was in the Lancet, similar patient population, patients who had stable angina despite medical therapy, but only single vessel obstructive disease. So 100 patients were randomized to PCI, and then 100 patients were randomized to a sham PCI, similar to Orbita 2. Patients had a 6-week intense run-in med optimization window And then invasive physiologic assessments were performed, but not visible to the operator. And then just as a side note, patients were on an average or a mean of about one anti-anginal med prior to enrollment, and they were increased up to about 3 anti-anginal meds at the time of randomization follow-up. In terms of the med optimization window, this is important as it relates to the difference between Orbita 1 and Orbita 2. It was very intensive, so patients had telephone consultations with the cardiologist up to 3 times per week. They had home pulse and blood pressure measurements. And the medications were introduced and up-titrated aggressively according to a protocol. And they had access 24/7 to a consultant cardiologist. And then by design, it was intentionally, knowingly intense to minimize the period of deferral for PCI to increase the likelihood of participation for people that they were trying to recruit. And similarly, the follow-up window was short so that people wouldn't feel like they were going indefinitely without PCI. In terms of the Orbita 1 trial, the primary outcome was treadmill exercise time, which was no different at 6 weeks. There was no difference in angio score or quality of life. The only significant result was a change in the peak stress wall motion scores on stress echocardiography that was a little bit better for the PCI group. So the major criticisms, this was all angiography-based, not pressure wire, physiologically based. So that may have underestimated the benefit of PCI versus the physiologic approach. It had a relatively short follow-up period of 6 weeks, and the med optimization phase was intense, questioning whether this is something that can be recapitulated in the real world, real clinical setting. And then the last trial I was going to mention is FAME2, including its 5-year follow-up results. So this was specifically with FFR, with invasive physiologic measurements, patients with stable CAD, angina, a severe stenosis, and at least one coronary vessel who are candidates for PCI, compared FFR intervention with OMT alone. About 440 patients for each group, FFR cutoff of less than 0.8. And then with an original follow-ups period of 7 months, but then they published 2-year and 5-year follow-up data. Notably, there was a benefit that they showed with death, MI, and urgent revascularization, but it was mostly driven by urgent revascularization. Most pertinent to this trial is that angina severity was lower in the intervention arm, up to 3 years following the intervention. This was adjudicated by comparing patients in either the trial arms to a registry group that they recruited at the time of enrollment. And it was basically looking at people who had class 1 angina versus those who had class 2 to 4 angina. PCI had lower angina scores at 6 months, 1 year, 2-year, and 3-year follow-up, but then didn't at 5-year follow-up. And then it's notable that this isn't on the individual patient level. This is just looking at the individual or the number of patients that have class 1 angina in each group. So then this led to kind of further questions following both of these more recent trials, with Orbita having a really high number of background anti-anginal meds, with high anti-anginal therapy that might be difficult to copy in practice. Patients might be more preferential to fewer meds or no meds. And then the question is, would elimination of anti-anginal meds entirely show any effect with PCI? And then especially if FFR and IFR were used to interrogate those lesions, would that improve the treatment success for angina? So that's where Orbita 2 comes in. It was designed to evaluate the effect of PCI compared to placebo in patients with stable angina who are not receiving background anti-anginal therapy. So I just put together a quick chart that compares Orbita 1 to Orbita 2. In Orbita 2, background anti-anginal meds were discontinued intentionally to compare PCI to a low amount of background anti-anginal therapy. PCI strategy was as an alternative as opposed to an add-on therapy. Primary outcome was exercise time for Orbita 1 versus angina score in Orbita 2 that I'll talk about quite a bit. The stenosis assessment was just angiographically in Orbita 1 versus angiographically and invasive physiologic in Orbita 2. It was multivessel disease in Orbita 2. The run-in period was shorter at 2 weeks compared to 6 weeks, and the follow-up period was 12 weeks compared to 6 weeks. So for patients to be included in Orbita 2, they had to be deemed clinically suitable for PCI. They had to have angina or an anginal equivalent. They had to have anatomical evidence of a severe stenotic lesions. They had to have ischemia in that stenotic lesion territory based on either non-invasive or invasive physiologic testing. So that could have been a stress echo, cardiac MRI, MPI, or IFR, FFR prior to enrollment. Exclusion criteria kind of things you'd expect: younger patients, patients with recent ACS, CABG, significant left main, CTOs, contraindication to PCI, severe valvular disease, or LV dysfunction. So at enrollment, patients completely stopped all anti-anginal meds. They were instructed on the use of a smartphone app that I'll talk about in the next slide here. They used the app, though, to report their number of angina episodes daily. They also completed some baseline testing, a couple of questionnaires. There was a clinical assessment of the Canadian Cardiovascular Society angina class. They did an exercise treadmill, and they did a stress echo. So for these 2 weeks, after they had completely stopped their medicines, they had anti-anginals that were put back on with a pre-specified treatment protocol that was individualized for each patient. If a patient didn't have any angina in the window, they were withdrawn from the trial. So essentially, patients were started completely from scratch in terms of their anti-anginal meds. If they were prescribed antihypertensives with anti-anginal properties, these were replaced with alternative agents that didn't have anti-anginal effects. And then medications that were used for other indications like heart failure or AFib rate control were continued and then incorporated into the statistical analysis. Patients had 24-hour access to trial personnel. And then importantly, despite patients reporting their angina scores on a daily basis, the actual protocol was triggered by patient contact. So a patient could have angina, 6 times a day, but if they weren't reaching out to the clinical staff, they wouldn't necessarily have any changement to their medical therapy. So in terms of the medical therapy itself, everybody was started on DAPT, both trial arms, with any of those 3 P2Y12 inhibitors listed. They were started on a PPI, they were started on a statin, atorvastatin 80 was preferred, they were given nitro spray. And then important and specific to this trial, they had a preferred sequence of anti-anginal meds that started with bisoprolol, nifedipine, Imdur, nicorandil, and ranolazine. I myself wasn't very familiar with nicorandil prior to this trial, but it is a guanylyl cyclase stimulator that increases cyclic GMP levels and causes vasodilation, decreasing angina. And then each patient had an individual basically plan that was set up with the treatment team prior that sort of set up a contingency in case they did develop worsening angina in terms of which medicine would be up titrated or started next. So the primary endpoint in this trial was an angina symptom score that was designed based around the smartphone app that they reported their symptoms to on a daily basis. And the symptom score was a composite of looking at these number of anginal episodes and then the units of anti-anginal medicine that were prescribed in that day. It ranged from 0 to 79, with more angina and more medicines leading to a higher score. If somebody was on 0 episodes, or somebody had 0 episodes of angina and had 0 meds, they would have a score of 0. Patients got the maximum scores, so 77, 78, and 79, for respectively unacceptable angina that required invasive coronary angiography, ACS, or death. And then major advantages of this approach compared to Orbit 1, there was temporal fidelity of the data, so patients were able to report their symptoms from the day prior right away. There was minimization of recall bias because they didn't have to think too far back in terms of when their symptoms were worse, and then data completeness was theoretically maximized. Interestingly, a couple things about the app: patients first define an angina in their own words, which I think is probably a pretty good approach because it can be protean and different for every patient. They had a diverse patient group that participated in the design of the app to see what they could workshop to make it more accessible to more patients. And then patients, if they didn't have, they were not English speaking and didn't have a contact that were capable of translating the app for them, there was a blinded member of the research team arranged using an interpreter service to look at the app with them. And so this is a chart that gives you a rough idea of what each of the anti-anginal meds and what their equivalence was. But the long story short is that a maximum dose for most of these meds was equivalent to about 2 units of their anti-anginal med score. And the way that they scored it is basically, you can see it's kind of graduated from 0 to 6 episodes of angina each day, starting at 0 anti-anginal unit meds, 1, 2, so on and so forth. So the maximum score achieved would be if someone was on 6 anti-anginal meds at full dose, which would be 11 or 12 units of anti-anginal meds with 6 episodes of angina or more a day. So the smartphone app, just a couple screenshots to give you an idea. It asked about the prior day. Did you have any angina? How many times? How bad was the episode? And then it gave you a little reminder, or a little thank you for submitting your symptoms. So some of the secondary endpoints previously mentioned, but treadmill exercise time, CCS class, and then 2 questionnaires, the Seattle Angina Questionnaire, SAQ, and the Euroqual's EQ5D5L, which was quality of life and self-perception of health, as well as a stress echocardiography score. So at the time of randomization, because this is a sham procedure, invasive coronary angiography was performed while the patient was wearing over-the-ear headphones with music. They had an invasive physiological assessment of each lesion again. So even if they'd had pressure wire analysis of the lesion before, they had it repeated at the time of the cath. They were withdrawn from the trial completely if the territory in question didn't have evidence of ischemia by pressure wire. And then they were randomized to a 1-to-1 ratio PCI to placebo. Patients that were randomized to both arms then received a deep level of sedation to where they weren't responsive to any form of verbal or tactile stimuli to make sure that they were absolutely blinded. So then the intervention arm underwent PCI of all lesions that had positive pressure wire analysis during the index procedure. And they, quote, encouraged intravascular imaging. The placebo arm was sedated for another 15 minutes following randomization without any other intervention. The operator and the research staff that were there for the randomization had no further patient contact, and then all subsequent staff was unaware of the group assignment, including the recovery room. In terms of follow-up, all anti-anginal meds were stopped again the second time after randomization. Patients slowly up-titrated on their anti-anginal medicines again with a 12-week follow-up period. They continued their daily symptom reporting, and then the same treatment protocol that was used in the first phase used in the second. Patients returned for baseline testing at 12 weeks, and then the test of blinding was performed at discharge and follow-up. There were a few issues with data collection that I'll just quickly mention. Because of the COVID pandemic, treadmills and stress echo visits were limited, so they used a statistical technique called multiple imputation to replace some of the missing data that had to be accounted for. However, this didn't affect their primary endpoint of the angina score, CCS class, or either of the questionnaires. And then if they didn't have daily symptom data available, they just reported the prior angina symptom score. This was only 2 patients that didn't ultimately have all their data reported, which is pretty good. This is the consort diagram for the trial itself. About 150 patients in each arm, and then 2 patients that were in the PCI arm that didn't undergo PCI, and 2 patients in the placebo arm that didn't undergo placebo was switched over. The 2 that didn't undergo PCI were because of multi-vessel disease, where one vessel took too long to treat, so they were worried about radiation, contrast burden, so they did not treat the other vessel. The patient was withdrawn from the trial. The other one had diffuse LAD disease that they thought would be better managed conservatively. And then the 2 patients that had PCI who were initially assigned to placebo both had pressure wire complications, so dissections that required intervention afterwards. So in terms of the baseline characteristics, listing it here, most notably middle-aged men makes up the predominant majority of the trial. Mostly, the vast majority of patients have normal LV function, and then the vast majority of patients had CCS class 2 or 3 angina. Kind of interestingly as well, of the patients that were enrolled, the vast majority of the patients had one vessel disease, so 80% of patients, even though they were specifically trying to enroll patients with multi-vessel disease. Only 17% and 3% respectively in the PCI arm had 2 and 3 vessel disease, and the majority also had LAD disease that's treated. Okay, so coming to the primary and secondary endpoints. So the major thing is that for the PCI arm compared to the placebo arm, there was a significantly lower angina symptom score at the 12-week follow-up period. This was mostly driven by mean daily angina episodes rather than mean daily anti-anginal use of medicines. And this is something that's shown here in this visualization, but you can kind of tell for the PCI group compared to the placebo group, if you especially pay attention to the green bar here, that the darker the green is, the fewer anginal episodes the patient had on a given basis. There was a big jump up at the randomization time. And you can see PCI compared to placebo that there's a much larger chunk of patients that have 0 anti-anginal meds and have 0 episodes of angina a day at the beginning. And that's kind of the difference between the two groups at the beginning of randomization. As the slope kind of decreases as time goes on, those are patients that have jumped over to these other groups in yellow, orange, and red who are on more anti-anginal meds and have more episodes of angina a day. Some of their secondary endpoints. So all of these did end up also being significant for the PCI group compared to the placebo group. So mean treadmill exercise time was significantly higher at 700 versus 640 seconds. CCS class on average was better. And then these are some of the domains that are explored by the quality of life and angina questionnaires, the SAQ and the EQD 5D5L. So frequency of angina was better, physical limitation was better, angina stability, freedom of life, and freedom from angina were all significantly better. And then the stress echocardiography score was also lower. And this is just another way to visualize kind of, rather than it being the patient-derived angina score, this is the physician or clinician-derived angina score. As you can see, there's about 2.5 times more patients that have a CCS score class of 0 and the PCI arm compared to the placebo arm. So briefly, a word about complications. There was paraprocedural MI in 4 patients in the PCI group with 0 in the placebo. All of these were procedural complications that was also included as ACS. In terms of spontaneous MI, 6 patients experienced spontaneous MI in the placebo group, 0 in the PCI group. I mentioned that there were some pressure wire complications in the placebo group. 1 patient was unblinded due to unacceptable angina. There were no deaths in either group. There were 4 major bleeding events total, with all patients being in the placebo group. 2 of them were related to access. 1 patient had a rectal bleed, and then 1 patient had epistaxis, keeping in mind that they were also on DAPT. And then there were 2 strokes, both of them occurring in the PCI group. And then of note, for all of those bleeding and the stroke complications, every patient remained blinded and then completed the study. So in terms of concluding and discussing, the author's conclusion was that in this placebo-controlled trial involving patients with stable angina who were receiving little or no anti-anginal medication and had coronary stenosis that were causing ischemia, PCI resulted in a lower angina symptom score than the placebo procedure, indicating better health status with respect to angina. This lower angina symptom score was affected more by the lower number of daily anginal episodes rather than the number of meds. The PCI group was about 3 times as likely to be angina-free by both the SAQ, the patient-derived, and the CCS, clinician-derived. The angina relief by PCI was immediate and sustained. They're highlighting the difference between Orbita 1 and Orbita 2, that without the significant background anti-anginal meds that might be difficult to achieve in the real-world setting, that there is a clear effect that's noted here with PCI alone. They also bring up prior data has shown that about half of patients undergoing elective cath are on 0 or 1 anti-anginal meds anyways, indicating that, it could be because of, patients having adverse effects, patients not being able to afford meds, patients not wanting to take meds, whatever it may be, that for what it's worth in a real world setting, patients really aren't on that many anti-anginal meds. And this was similar to the data that was found at time of enrollment for both Orbita 1 and Orbita 2, that patients were on a median number of full dose anti-anginal meds of 1, despite them having severe coronary disease with proven ischemia. This is also kind of an interesting thing that they mention. They bring up that even though they deviated from guideline-directed care, that by only reserving PCI for those that don't respond to anti-anginal meds, we might be selecting the cohort with the least to gain. And that is to say that Orbita 1 didn't show a difference between the 2 groups. And that may have been because they were on such high anti-anginal meds, and that if we're proceeding with the guideline-directed plan of care, which is the current paradigm, we're exposing patients to a risky procedure and to DAPT in a group of patients that might have the least to gain from a marginal benefit standpoint, which is also kind of echoed there at that first point. And then also just kind of interesting and shows a little bit of the power of the placebo effect. The treadmill time in the current trial was 60 seconds longer compared to the placebo arm. And this is compared to the ACME trial, the first trial I mentioned, which was 96 seconds longer, which is an impressive difference between two groups, and that's still 1.5 times longer that of the current trial. And that other trials have shown that with a single full dose anti-anginal med, that patients will have an increase in their exercise treadmill time between 45 seconds and a minute, basically. My major takeaways is that you should still seek to find at least one anti-anginal medicine that can be up titrated to a full dose, or more than one that can be titrated at lower doses to improve symptoms and functional status and have quality of life, all comparable to PCI. Because in the real world setting, you wouldn't be deprescribing every single one of their medicines. I was a little bit surprised by the rates of spontaneous MI relatively between the two groups. Also noting that the number of paraprocedural MI was about the same compared to the rate of spontaneous MI. I was also surprised by how low overall the angina burden was, the angina scores were. If you think about it from a scale from 0 to 79, in patients with possibly multivessel coronary disease and proven ischemia, their scores were only 2.9 and 5.6 respectively. And then just kind of mentioning again that there is clearly a complicated relationship of these kind of separate three spheres of anatomy, physiology, and symptoms, and it's not really as linear of a relationship as we would hope between the three, but this the current trial supported that if there's a stenotic lesion or lesion encroachment on a vessel causing supply-demand oxygen mismatch and ischemia, that this can, treating this can improve symptoms. And then last slide, just talking briefly about the trial limitations. It was a 12-week follow-up, which was admittedly still pretty brief. And the big picture, care was a deviation from guideline-directed recommendations. Also, the authors did mention this, but the trial was meant to interrogate a population with single and multivessel coronary disease, but only 80% of patients ended up being treated for single vessel disease. The smartphone app was only available in English, and also the population that was enrolled as a show was a middle-aged male patient population that had normal LV function. And then also just mentioning the secondary endpoints, that there was missing data because of the COVID pandemic, and I was unable to find exactly the extent of how many patients had missing data or from how many time points. And that's all I got. Open for questions.
Thanks, Andrew. I mean, a good trial. To me, this just highlights how difficult it is to do a trial like this. All the acrobatics essentially they had to do with the blinding and the app and everything else to get sort of as clean data as possible. It's pretty telling. But yeah, no, it seemed to work. I don't have any particular questions. Anyone else? Any questions or follow-up comments regarding this trial? Well, yeah, I guess you've answered everyone's questions. So good. Anything else, Andrew, from your standpoint? Any other editorializations you have, or you covered everything?
I think just kind of the last thing is just kind of funny at its most cynical. The conclusion I had, like after finishing the trial, was, well, duh. This is basically just supporting what ACME and some of the older trials showed. But if you look at it from the other perspective, that a lot of our initial conclusions about ischemia and angina were based off of studies in dogs and ligating their coronary arteries, and a lot of our kind of treatment approaches was based off of not necessarily super sound data like the ACME trial listing some of the limitations there. That this is actually a very kind of cornerstone article, and that it kind of proves the way that we've been managing a lot of different patients for the past couple decades actually does have some backing.
Yeah.
And yeah, definitely, as you mentioned, it's really difficult to get good data on symptom scores.
Yeah, no, I agree. I mean, you're right. It's trying to, if you could poke holes in some of those prior trials, this is designed to sort of eliminate your ability to poke hole. It's just all they have to go through. Be like, all right, well, whatever issues you might have had with those prior trials, this was designed to hopefully address those issues and support that. What we're still doing is that, this treatment does help angina in folks with sort of chronic stable angina. So, okay.
I was just gonna give Robert. So I'm sorry. Just one just quick comment. I mean, two quick things. I would just say that this really is an outstanding trial, and really, if we're gonna do things in cardiovascular with quality of life endpoints, we really should have sham. So I think that we can do this in all of our procedural, aspects of care and have a sham control, because this is really awesome. And the second thing I would just say is that I think it shows that if we bring patients to the cath lab that have angina and coronary disease, but not necessarily have to look for ischemia, we'll find a group of patients that will be much more likely to benefit. So I think it really highlights doing treadmill testing to look for angina and CTAs to look for coronary disease. And if we bring the patients with a coronary disease and angina on the treadmill to the cath lab, we'll probably have a much more enriched patient than using pharmacologic nuclear stress testing. So that's my only.
Thank you, Dr. McDaniel. All right. Our next presenter is Dr. Khawaja. Muz is a second-year fellow in the clinical track, did his residency at Baylor, and I forget which study he is going to talk about, but he's going to talk about something. So, Muz, take it away.
Good morning, everybody. Thanks for chiming in, joining in. So I'll get started. Thank you for the introduction, Dr. Williams. I have no disclosures for this talk. So I'm going to be going through the FIRE trial, which was published back in September of this year. It was published in the New England Journal of Medicine. This was looking at culprit only versus complete revascularization in elderly patients, which we'll define for the purposes of this talk as older than 75 years of age, that were presenting with myocardial infarction. Before I get to that, I'll just kind of lay the background in terms of, how does MI present in these patients? What are some of the issues and challenges that we face in managing these patients with revascularization? And what does the current literature show in terms of culprit only versus complete revascularization in general for general population presenting with acute coronary syndrome. And then we'll talk about the trial going through a PICO format, and then we'll talk about some of the clinical implications and kind of future directions and kind of unanswered questions that we may still have after the trial. So as we know, acute MI is like one of the leading causes of mortality worldwide. And one of the important predictors of outcomes and morbidity after MI for these patients is their age. A lot of data is showing that there's an increasing proportion of older patients, older than 75, that are being admitted with acute MI. This is likely secondary to, obviously life expectancies are increasing. We have advanced therapies. We have better means of diagnosis in these patients across the board. So, but it is an important fact to recognize. In the United States, about 35% of MI actually occurs in patients that are 75 and older, and about 10-11% occurs in patients actually 85 years and older. In this patient population, it's important to recognize that the more common presentation in terms of MI is actually a non-STEMI, but you can have STEMIs in these patients, and the absolute number of STEMIs does increase with age. And if you do have older patients that do present with STEMI, they are at higher risk for hemodynamic compromise, cardiogenic shock. They're at more risk of complications from revascularization procedures such as stroke, obviously bleeding, and overall mortality. So it's important to just kind of recognize these background challenges with some of these patients. This was a nice little illustration of a table here from Jack that was kind of trying to capture all the nuance in terms of assessing older patients when we're thinking about revascularization. Obviously, you have to consider the physiologic and hemodynamic risk for these patients. They're at higher risk for heart failure, for cardiac arrest, cardiogenic shock, which I mentioned, complications from the procedure itself. But there's also important anatomic and procedural things that you have to consider with these patients, looking at more calcified vessels, more tortuous vessels. And then also there are things to consider in terms of risks that are not specific to the actual revascularization procedure. These patients are more frail. They often have multiple medications. So there's the issue of polypharmacy. They may be disabled. They may be at risk for falls, which could affect your antiplatelet therapy going forward. So it's important to kind of look at the entire spectrum of risk across this patient population and really consider each patient individually, which I'll kind of talk about a little bit later, when you are thinking about revascularization and management of acute coronary syndrome in this population. So this is just a kind of, it's not an exhaustive list, but these are some of the challenges that we face in these older patients. They often present atypically. They'll most commonly present with chest pain, but they can often present with shortness of breath, nausea. They may present with syncope, and this could lead to delays in diagnosis, delays in presentation to the hospital, delays in treatment, which can often portend worse prognoses and mortality overall. They often have multiple comorbidities. They have higher ischemic and bleeding risk profiles. Obviously, the cognitive impairment, sometimes that you see in some of these patients, frailty. And then I mentioned earlier that they may have more complex lesions. And then the big thing to note is that we don't have a lot of data in terms of guiding management of acute coronary syndrome in older patients. Even though a third of patients presenting with MI are older than 75 and 2/3 dying from MI older than 75, we have less than 10% of patients in trials that are older than 75. So it's important to recognize that limitation from the trials that we do have. I wanted to just highlight as we know, the pathology of acute coronary syndrome. It's basically the same in older patients. Atherosclerosis, it's a chronic process. You have development of this, an endothelial injury, lipid deposition, leading to inflammation, atheroma formation, which has a necrotic core, fibrous cap. And then you see increased calcification as patients get older. But the main mechanisms for acute coronary syndrome in these patients, as in the general population, is most commonly plaque rupture, followed by plaque erosion, and then calcified nodules. But it is important to note that calcified nodules, the proportion of this etiology does increase as patients get older. But it's essentially the same kind of pathology, which can factor in sometimes in terms of how you manage some of these patients. So this is just some pathology slides depicting, the plaque rupture, as we know, where you have disruption of the fibrous cap leading to, infiltration with inflammatory cells and causing platelet aggregation, thrombus formation. Whereas plaque erosion, you maintain integrity of that plaque, but it does still lead to thrombus formation. And then calcific nodules, which is essentially these sheets of calcium that form these nodules that can be associated with thrombus. As I mentioned, these patients present atypically, and this can lead to longer delays in treatment and diagnosis and reperfusion potentially, which can lead to worsened outcomes. So then I'm going to pivot over to what percentage of patients, what does the data show in terms of patients who present with MI, how many of them are found to have significant, quote unquote, significant multivessel lesions that are not infarct related or non-culprit lesions. There is some data to kind of show the trends in this region. One study showed that in patients presenting with STEMI, about 40 to 60% actually have significant multivessel coronary disease that was defined as luminal stenosis greater than 50% or FFR less than 0.8. And in these patients who do present with STEMI and significant multivessel disease, they do have worse prognoses. This was shown in one study that had about 2,000 patients that underwent primary PCI, and essentially it showed that if you had single, double, or triple vessel disease, as we would expect, you have a higher rate of cumulative incidence of death at 1 year if you're incidentally found to have multivessel disease. And there was a separate study that showed that patients who presented with STEMI were found to have an incidental CTO of another vessel, the mortality was higher in those patients, as we would expect. So what are the current recent trials that kind of guide our guidelines and our consensus in terms of revascularizing non-culprit lesions in patients who present with MI? So these are not all the trials, but these are some of the most commonly cited trials, especially in the European and American guidelines for revascularization. So I'll quickly go through these. I won't spend too much time. The DANIMA-3 trial, Primulti trial, was in 2015. It was an open label randomized trial. It was across, I think, 2 hospitals in Denmark, and it had around 600 patients or so. These are patients who presented with STEMI. that had significant non-culprit lesions. They were randomized to either complete or single culprit vessel revascularization. This was actually guided by FFR assessment. And they looked at their primary endpoint of, which was a composite of mortality, reinfarction, and revascularization at 1 year follow-up. And they saw that the primary endpoint was actually significantly more frequent in patients who had infarct only PCI as compared to patients who had complete revascularization. The complete trial, kind of similar, also included patients with STEMI that were randomized essentially to complete revasc or culprit-only revascularization strategy, and showed similar findings that the complete revascularization strategy was superior to culprit-only in terms of reducing cardiovascular death or myocardial infarction. This trial, I think, was from 2019. This trial, the Compare Acute trial from 2017, was also looking at STEMI patients. And in this trial, they did use a physiologic assessment with FFR, and also saw that there was a lower composite cardiovascular outcome seen in patients who had complete revascularization as compared to those who had infarct related only. So kind of they're all demonstrating similar findings. And then the SMILE trial was notable because this actually included non-STEMI patients. It was about 580 patients that were randomized 1-to-1. This trial looked at single stage versus multi-stage PCI, and found that in patients who had single stage PCI, the culprit lesion presenting with NSTEMI were found to have a significantly higher endpoint outcome. So all of these trials kind of are demonstrating that, suggesting a benefit associated with complete revascularization in patients with STEMI as well as NSTEMI. More data available on the STEMI presentations. However, the issues with this trial is that for older patients, you can't generalize these findings because they didn't have a significant number of older patients. I think the median age across these 4 trials was actually 60 years of age. However, there was a meta-analysis from 2022 that actually looked at these 4 trials and specifically looked at patients older than 75. This was published last year, and they looked at all-cause mortality. They also included some secondary endpoints, the most meaningful one being the net adverse clinical events, which was a composite of death, MI, stroke, and bleeding, and actually saw that there was a signal suggesting benefit to multi-vessel PCI as compared to culprit only, because there was a significantly lower risk of these adverse clinical events in the complete revascularization strategy. But again, this was just a meta-analysis. So the question is, what do our guidelines say? So the ACC/AHA SKY guidelines actually give a class 1 recommendation, citing these 4 clinical trials that I mentioned, mentioning that, patients who are hemodynamically stable presenting with STEMI, so this is, they comment on STEMI patients, but did not make a specific designation for non-STEMI patients, that after successful primary PCI, you should consider stage PCI of a non-infarct artery to reduce the risk of MI or death. And this was, again, mainly driven by their findings found in the 4 trials I mentioned previously, and that benefit in those trials was primarily driven by a reduction in the risk of having repeat revascularization or reinfarction. Meanwhile, the European guidelines from 2018, albeit it's 5 years ago, but they do mention a class 2A recommendation for revascularization for non-infarct related arteries prior to hospital discharge in patients who have multivessel disease. And this is also in the setting of STEMI, but no clear specifications for non-STEMI or NSTEMI patients, given the lack of data in those patients. This is also interesting, I thought, to mention that the 2021 ACC guidelines did mention that if you do have older patients, as in all patients, but they made a specific point about this, is that your treatment strategy, you should take into consideration all the things in the patient spectrum that we kind of talked about: patient preferences, their cognitive function, life expectancy. And that kind of gets to the illustration I showed at the beginning, that these patients, we have to take all of these things into consideration when we're thinking about management strategies in terms of revascularization. Is the benefit, is the risk really worth the benefit? So this is the FIRE trial, functional assessment in elderly MI patients with multivessel disease. It was a multi-center prospective randomized trial published just a few months back. We'll kind of go through it through a PICO format, but essentially it was looking at physiology-guided complete revasc as compared to just culprit-only strategy in older patients. The patient population that they included were patients older than 75 that presented with STEMI or NSTEMI that had undergone successful PCI of the culprit lesion and then were found to have at least one significant other non-culprit coronary lesion that was defined as greater than 50 to 99% stenosis, and the vessel diameter had to be at least 2.5 millimeters. They excluded patients who had prior surgeries or were planned for surgical revascularization if they were unable to identify the clear culprit lesion when these patients presented with MI. And then they also excluded patients who had non-culprit lesions in the left main, but they did include patients who had culprit lesions in the left main. So you did have representation of that patient population as well. And they excluded patients who had a life expectancy less than 1 year. So they recruited patients between 2019 and 2021. And they ultimately had around 1,400 patients that were randomly assigned to either complete revascularization guided by a physiologic assessment of quote unquote significant stenoses versus culprit only. So these are just some of the characteristics of the patients that I think are worth noting. As I mentioned earlier, the median age is around 80 years. They did have a good spread of, as you would expect, of the comorbidities that we often see in these patients: hypertension, hyperlipidemia. They had about 35% of patients that presented with STEMI and about 65% that presented with NSTEMI. Median ejection fraction was about 50%. So these are just some notable baseline characteristics and no significant differences. So about 700 patients in each arm. So these patients were randomly assigned 1-to-1 to have physiology-guided revasc or complete revascularization versus culprit only. The physiologic assessment was conducted by wire-based methods, so looking for defining as either hyperemic or non-hyperemic, and then using quantitative flow ratios, so FFR, IFR. They defined a significant non-culprit lesion as hyperemic, non-hyperemic, or essentially looking at angiography quantitative flow ratios of 0.8, 0.89 or less. And then the patients who were randomized to culprit-only revascularization, obviously they did not have any further physiologic assessment of other lesions or revascularization. These are just some of the procedural characteristics that were notable. I thought it's interesting to see that there were some patients who in both arms that did have culprit lesions in the left main. About 5% of patients. Most commonly involved vessel was the LAD, followed by the RCA and CIRC. Interestingly, about 30% of patients had more than 2 vessels that were non-culprit vessels in both arms. And then in terms of these non-culprit vessel locations, it was kind of evenly spread across the LAD, CIRC, and RCA. The primary outcome that they looked at was a composite of death, MI, stroke, or revascularization at 1-year follow-up. And then their secondary outcomes were essentially the individual components of this primary outcome, as well as they had a secondary outcome of a composite of cardiovascular death or MI at 1 year. They also assessed safety outcomes, looking at acute kidney injury, stroke, or bleeding at 1 year. So we'll kind of talk about these results, but essentially what they found was that there was a significant reduction in the primary outcome seen in the complete revascularization group, which had about 15% of patients having the primary outcome in the complete revasc group, whereas 21% of patients in the culprit-only revascularization group had a composite of death, MI, stroke, or revascularization. There was also a significant difference in terms of the secondary outcome of cardiovascular death or MI that signaled the benefit or an advantage with the complete revascularization group. And it was interesting to see that this effect of complete revascularization, although it was not significant across all subgroups, did suggest a signal favoring complete revascularization. for across, whether it was based on age, diabetes, ejection fraction. So this was a pretty consistent finding across these subgroups. And there was also no significant difference in terms of the safety outcomes between the groups, which I was a little bit surprised to see, because I intuitively thought that there would be higher risks of, complications. Obviously, these patients are having multivessel PCI with the complete revascularization group, but there was in their trial, there was no significant difference. So as I mentioned, the primary outcome was occurred about 15% of patients in the complete revasc group, as opposed to 21% in the culprit only. Aside for the individual outcome of stroke, all of the other individual components of the primary outcome were essentially lower in the complete revascularization group, and there was no significant difference in terms of the safety outcomes between the two arms. So the big thing to note, I think, was that, obviously this trial demonstrated that there was a relatively lower risk of the composite of death, MI, stroke, or revascularization, about 27% the complete revascularization arm. And this benefit was even seen in their individual components, aside for stroke. It demonstrated that in their secondary outcomes that there was actually a 36% relative reduction in terms of cardiovascular death, or MI. There are a lot of strengths to this trial. Obviously, it gives us some more information in terms of how to manage these patients, because they can be very challenging logistically, therapeutically. The other advantage is that this patient had older patients, as I mentioned. Their median age was around 80, whereas the prior 4 trials that I mentioned that formed the basis of our guidelines and our current strategies for managing STEMI patients is that those trials have patients that were around the age of 60. So this kind of helps provide more insight to our older patients that we are encountering more frequently. And then the other benefit is that this trial included STEMI as well as non-STEMI patients, with a significantly higher proportion of NSTEMI patients, which hopefully will guide future guideline changes and recommendations. And also, I think it's beneficial that they included physiologic assessment to help guide their assessment of whether these non-culprit lesions were actually significant or non-significant. Of course, there's limitations, as with any study. It was an open label design, so this does introduce bias potentially among patients and physicians, especially in the culprit-only treatment group, towards potentially favoring revascularization subsequently. Again, it's difficult to generalize these findings to revascularization in the community setting that may not always be guided by physiologic assessment. There are plenty of interventionalists who can determine solely angiographically, whether a stenosis is significant or not. And then obviously the PCI that they actually looked at was drug-eluting stents, implantation with sirolimus-eluting stents. Obviously, we can't generalize it to other PCI strategies, whether that's HOBA, whether that's drug-coated balloons, whether it's a combination of one or two of the other. And then obviously other drug-eluting stents were not included. So those are some of the limitations, but I think this trial does offer some insight into this older patient population and what we could potentially do if we were encountered with a patient that has multivessel disease in the setting of STEMI or NSTEMI. Obviously, we need more randomized trials in this area, especially for NSTEMI patients, because there's just a significant lack in that realm. We need better criteria, potentially. Maybe there's a role for standard patient selection criteria to determine which elderly patients are suitable candidates for complete revascularization. Not every patient should be. As I kind of mentioned previously, it's important to assess patients overall, comprehensively. And maybe there could be a benefit of having standardized tools for assessing frailty and maybe trying to incorporate them into clinical decision-making. We do need longer-term outcome data. I mean, a lot of this data that we have is most of all the trials that I mentioned today is all 1-year follow-up. And so we do need kind of more long-term outcome data to kind of tell us a little bit more about this patient population. Is it truly beneficial or not? Do we maintain some of those mortality benefits that we've seen and all those other benefits that I mentioned? And then obviously, it's still unclear whether other PCI strategies such as POBA, drug-coated balloons, or other strategies, more complex interventions, can be useful and beneficial in these patients as well. obviously they come with a different sets of risks as well, but it would be interesting to see whether we could further define which PCI strategy may be better. And then maybe there could be a role for having multidisciplinary teams, including some of our colleagues, such as geriatricians, maybe the palliative care physicians, who are better adept at assessing some of these patients, these older patients, in terms of clinical decision making and guiding whether, how aggressive we do want to be. Because although there is a benefit, as seen in many of these trials, it may still be useful to consider some of the other factors that I mentioned in this older patient population. So that's all I have.
Thank you, Muz. Very good. Quick clarification. I think you said this. I think I missed it. The multi-vessel PCI was done after it was staged, right? It wasn't done at the time of presentation.
It was staged, yes, sir. It was staged.
Yeah, I mean, this certainly mirrors trials done in other non-coronary areas. If you look at hypertension management trials in elderly and AFib management trials in elderly, the benefit does tend to persist, maybe not always to the same degree, but certainly does seem to persist in patients. But I think you're right. I mean, I think a thoughtful approach, that it's a reasonable approach in appropriately selected patients is probably the way to go. So questions, comments from the group?
Muz, Stan Sherman. I didn't hear anything about the medical therapy, during this trial and the comparisons and the patient's ability to take guideline-directed medical therapy. Any comments on that?
Yes, sir. So they did put here in this table here, they did have a significant number of patients that were in both arms that were predominantly on antiplatelet therapy, most commonly being aspirin. You did have a significant portion of patients on Plavix and Brilinta and Effient as well. But I don't know if they mentioned in terms of adherence patterns and things like that, but there was decent representation of the antiplatelets that are commonly used.
I think in this age group, it could make a big difference in terms of what they could tolerate, medical wise, and couldn't tolerate medical wise, at least in terms of thinking what you want to do.
Yes, sir.
Initially.
Absolutely.
Hey, Moose.
Yes, sir.
Good work. I've always thought that frailty was a big factor, and when you take the frail little lady, put her on the table with an acute MI, that person's life is in danger. And in that situation, it seems to me simpler is better. And I think that it takes a lot of judgment in that situation to decide whether or not to fix another lesion. I know there's a lot of effort to look at these with FFR from all the previous trials and make decisions along those lines. But a quick in and out in the frail little lady, I've always thought was a good approach. And as Stan is mentioning, there is such a thing as medical treatment for lesions that look like they're borderline and they're smooth and they don't have irregularity to them. Mm-hmm. And you always fear of someone trying to treat 3 lesions in older, frail people with acute situations, and one little bobble in the entire situation will sink the ship. So,
yes, sir.
I think in the background here, there's thoughts about being conservative, also careful.
Yes, sir. Absolutely.
I was also, Stan again, I was also impressed with the fact that there wasn't a lot of renal problems. Was there a cutoff for the whole question of renal problems after the revascularization?
Yes, sir. They did use the standard cutoff for acute kidney injury, but I don't remember off the top of my head what they actually used, but I think they did use the standard acute kidney injury based on the BART criteria. But
I mean, was there a level where they said we wouldn't do the other lesions? Did they mention that, or they didn't really mention it?
no, they didn't really mention that in terms of like chronic kidney or acute on chronic kidney injury. I didn't see that mentioned in their trial.
Okay, good talk.
All right. Well, thanks again to everybody for tuning in, and thanks to Muz and Andrew for presenting. Happy holidays, everybody. Faculty, make sure you claim your CME credit, and we will see everybody in 3 weeks. We're off the next 2 weeks. We'll see everybody first Friday in January. Take care.
The preceding program is copyrighted by Emory University.